Good afternoon, everyone. I welcome you to this e-seminar, which is today organized by the DESCarTES working group, the transplant working group of the European Renal Association. My name is Bruno Watschinger. I'm a nephrologist from Vienna, Austria, and I'm very glad that we have such an important faculty together with our speaker today. It's Geir, who is a consultant nephrologist in Oslo, in Norway. Alessandra Grossi, she's professor of the University of Insubria in Varese in Italy, and she's specialized and a specialist in health communication and medical ethics. And as another panelist, Professor Christophe Mariat, who is head of nephrology, dialysis and transplantation in Saint-Étienne in France. So I think we will have a nice topic and a nice discussion. As you know, today's topic is preparing and informing potential living kidney donors. Before we start, though, I would give you some few hints which I was asked to provide you from the association. There is a real-time translation, audio and captions with artificial intelligence that you can use in 7 different languages: French, German, Italian, Portuguese, Russian, Spanish, and Turkish. And in order to enable the audio, you have to click on the globe icon at the bottom near the pause function and choose your language. So I hope you will be using this new feature. And for the captions, an external link to access through the browser will provide it within the chat. You are also most welcome to send us your questions in the Q&A part of the Zoom, so we can see it and that we can answer it. And most importantly, you will be provided with 1 European credit for continuous medical education. This is for ERA members only, and it's mandatory that you fill out the questionnaire feedback at the end of the seminar. So with all this information, we will just go ahead now and ask Geir to give us his presentation, which will set up the stage for a hopefully very interesting discussion afterwards.
Thank you for joining our CME e-seminar. We have been working on this for a few weeks now, and we hope that you will ask some questions during the e-seminar using the Q&A function, and we will try to answer all questions. These are my disclosures. So I will first try to give you some background information on the subject of living kidney donation in general. And then I will try to go through a few definitions that are new, I would guess, to most physicians. At least they were new to me when I started working on these subjects. And finally, I will present the paper that we published last year, which is what has led us to work further with this subject in the DESCarTES working group. So living kidney donation is known. It's been performed since the 60s as a routine treatment for end-stage kidney disease, and I think all nephrologists would agree that this is the best treatment that a patient can get. But there is a dilemma here, because it exposes a healthy individual to some risks for the benefit of someone else. the research that has been published to date lists perioperative complications. That's quite easy to imagine that this is a possibility. As more long-term risks, there are the risks for hypertension, and in women in subsequent pregnancies, and increased risk for preeclampsia. There is no increased risk of getting any kidney disease, but if you are so unlucky that you do, you will have less reserve capacity than if you started with 2 kidneys, so your risk of ending needing renal replacement therapy would also be increased, although I would say that this risk in absolute terms is quite small. And finally, there may be an increased risk for mortality or cardiovascular mortality. So these are things that make up this information that we use when counseling those who are considering living kidney donation. And in the past, there has been a survey of health workers working with transplantation, kidney transplantation in Europe. And the survey was performed by the DESCarTES and the IKITA working groups. And there is a publication in NDT, and it is available if you search for it. This survey was performed so that we had individuals responsible for each country, and they would contact people in their network, and those people would forward the survey further, so that we wanted to have responses from people that we knew actually worked on this subject or in this field. So for that paper, which is not the main paper that we are talking about here today, but the paper that led us in this direction, the main findings were that there were just didn't seem to be any patterns. There were large variations in which risks were communicated. There were large variations in how the risks were presented, and this variation seemed quite random. So here is a figure from this paper, and these bars tells us that the different risks that are known were some of them were rarely discussed or disclosed, and some of them were always discussed or disclosed. When we looked at the map and the demographics and the characteristics of respondents, we saw that there were differences between institutions, between different occupation groups, between individuals at the same institution, between guidelines. There were really no uniform standards about how to counsel donors. So after working on this, we kept the discussion going, and we wanted to create a framework for this obtaining the informed consent in advance of donation, and we wanted to achieve or help achieve some type of standardization. So we worked on this. We worked on this with Alessandra Grossi, who is here today with us. And we wanted to see how this variation that we saw in our initial project could perhaps be improved in several different ways. And we wanted to create some type of recommendation, a recommendation that said something about how information is provided, when should it be provided, and how do we ascertain that we have actually informed consent to a degree that we deem is acceptable. So there is, from the Oxford Dictionary, there is the definition of informed consent, because we use these words a lot, and it says that informed consent in general is permission from a patient for a medical professional to carry out treatment with complete understanding of the possible risks and consequences. Our experience after working with this is that informed consent is not a signature on a piece of paper obtained by visiting a patient at the bed and within some time constraints during a busy working day, but informed consent develops easier after or over some time. And for donors, it would be that in-depth, well-informed decisions should include receiving information of all potential risks associated with living kidney donation, emphasizing short and long-term medical and surgical risks for the donor. And the other concept or expression that we are using here today is shared decision making. And shared decision making, you will hear others talk about this too, is that decisions are made in a collaborative way. Information is provided in accessible formats. And it's typically in situations where personal circumstances and context of patients play a major role. So on the other hand, some settings where you have no time, patients who are maybe not fully conscious or do not have the ability to consent, and maybe they have no family there as well, then those emergency situations or stuff like that, that is not what we are talking about, but we are talking about situations where you may have the time and where it is very important to use this on the way to obtaining informed consent. And maybe you could say that shared decision making is what happens along the way to a decision, and informed consent is hopefully where you would arrive. So we have discussed within our group, and we have created a paper that is a recommendation. And this recommendation is based on other papers. It's based on knowledge, it's based on opinions, it's based on group discussions. So this is not research based on studies with many donors. And this the specific recommendations that we have made, we have not tested them. So right now, this is in the realm of expert opinions. We thought about several ways of creating the paper, and we wanted to have involvement of nephrologists with clinical experience, and we were very lucky to have Alessandra take charge in this project and lead us in the direction of informed consent and theoretical knowledge, and helping out, making this a system that hopefully will be of use in clinical practice. So this is actually a picture of our model, and this is 3 steps, and it's a 3 steps model, and it's in the direction of living kidney donation. So if you start here in this part, we call this the first step, and we say that if we say that this is team talk, this is the step where a patient arrives at a hospital, maybe not needing renal replacement therapy, but with declining kidney function, and the patient needs to get some education about this as an option, and the family of the patient or people around the patient would in some way need to receive information in writing during conversations, taking time with questions and answers, and also trying to figure out what what is the patient comfortable with, what does the patient want, potential donors, if they contact the hospital themselves, if the hospital or health workers contact them in some way, and what are their individual preferences, what do they want, what are their needs, what do they know, and then when someone is actually stepping forward, we could try and move to this next part, where we more specifically try to learn about the risks and benefits of living donation. And if you're going through a medical procedure, then teaching people about benefits is nice, but what is most important is teaching them about the risks, because if something actually happens later on, it's important both to have communicated these risks and to have satisfactory knowledge that they are this information is indeed understood. So this is a time for more specific answers and questions, discussions, and this also is something that evolves over time. So when we go to this last part, which is what we call decision talk, we would say that this is the part where we go through some of the information or all of the information again and try to ensure that this is actually understood. We may want to test with some type of written test or oral, or we would like to have maybe easy access to some type of health worker that could be reached by telephone when the living donor themselves have an initiative or want to discuss something, so that it can be a little bit on their terms. And maybe this is where you make the decision, and this is where you should question the motives again and make sure. So to try and take some of these examples over again is this part that we call team talk is actually impossible to start early enough. Sometimes potential donors that grow up with siblings who will later on need renal replacement therapy will sometimes have heard about this several years before it's actually necessary, and others will be in different situations and will not have heard about even the possibility when this situation arises. So for both patients and potential donors, there will be large individual differences in when this is actually communicated in relation to the time of transplantation, if that happens. So this structural education could be implemented in educational sessions that are routinely performed for patients and their next of kin or friends. It could be done at the hospital, or sometimes it could be done out in the field in society, in home-based plenary sessions. At this point, you usually do not know who the potential donor is, but you are just passing out, or not just, but you are passing out information to the friends and family of the patient, people themselves out in society through internet and friends and social media will have much easier access now than a few decades ago to all types of information regarding risk, and this also has to be taken into account and should be also a part of these sessions or conversations. It's a goal to have some kind of standardized materials that you use in your daily practice, and it's a goal to have perhaps a system or structure of what kind of information you want to deliver and when and how. And you can open up by also saying how they could contact the hospital if they, on a more individual basis, would be interested in knowing more about this. To be even better, you could give out some sheets with common questions surrounding the act of a living kidney donation. So questions that have something to do with alternatives or complications, or what could affect the donors later in life. How much time would a donor need for all this information? That would vary a lot, I think. It would vary according to the personality type, how much do they know from before, and how much interest do they express themselves. So when an individual donor has made contact, you have not decided anything more than that they are interested in this. You would have to have maybe some type of health personnel in your clinic who is interested in this, who is gaining experience, maybe has a lot of experience. Maybe you are a team, because now maybe you would like to find out what matters most to this potential donor and try and incorporate that into answers, questions, and conversations. Maybe you would like to individualize, but on the other hand, you would also like to convey risk information that maybe the potential donor didn't know about, but that you feel obliged to share. And at this stage, it's also important that there could be someone or some part of the system that is available to the donor so that they can make contact themselves when they have questions and are ready or open for discussing the matter further. To convey risk information, it would help if you have some type of visual aid, some type of patient information material. It's in our days, we talk about health literacy, and it's nice to think about who is in front of you and try to take the time needed and try to use the appropriate language when you are explaining or when you are discussing these different types of information that would be relevant to the potential donor. It's always a goal to try and give out specific numbers and frequencies, but we are not always able to look into the future on behalf of the individual in front of us. So it's also, I think it should also be allowed to give out more qualitative measures, although that is not seen as the optimal solution. Many times trying to state specific probabilities could be quite difficult. So when you are going even further and it's becoming a real possibility that you are going to go in the direction of living kidney donation, it's you could try and find out what do you base your decision, how do you assess this risk. Maybe the potential donor could tell you what do they know, what do they think, what are their opinions, would they like to talk to someone who has already donated a kidney, do they want to talk to another health worker with another specific expertise, should you do some type of formal assessment, is it important to grade or try and find out if there are holes or gaps in the knowledge of the living kidney donor at this stage. That is less likely, but it is also a good quality control if you could have some type of easy test that is not meant to humiliate anyone, but which would be could be a basis for a discussion, or that could be just a checklist to see if you have covered everything. So you should usually there in the health system that you work, there will be some type of regulation that you should have a formal documentation of the things you have talked about, what you have done to try and achieve this level of informed consent, and there will be different solutions or there will be different systems, but usually according to legal needs, there would be a need for having formal documentation in the patient chart or file or in the donor's chart or file. So this is the things that I have shown you on the slides now, and a few more recommendations, and try to group them by the time during the 3 stages, and it's you could say that this could be used as a checklist or an inspiration for someone who would like to create a system for informing donors, and it could be used also for discussions, and maybe it could be tested or changed, or but at least as a basis, we think that this is a good method. And since it is a circle, it doesn't always work in the steps that we showed you. Maybe sometimes you have to go a little bit back and forward. and maybe not everyone follows the same steps. So this method is maybe not very different from what some centers practice already today. Having this type of structure could maybe it could create the confidence, maybe it makes it easier for doctors and nurses, other health personnel involved. Maybe it creates frustrations. Maybe you would like to have it simpler, easier, and with fewer rules and recommendations. And it's likely that there could be many different ways of organizing this type of system within any specific health center. So most likely it should be tailored not only to doctors and donors, but it should probably be tailored to individual hospitals or clinics where you would try to implement this. You would have to see what kind of resources do we have, what are we used to doing, and how could this be an inspiration, or how could this guide us further? So here we have this system, and maybe we are at the first of these 5 steps that we have now. We are now filled with a recommendation, and we are filled with good intentions, and maybe we would like to test this out in some way. Maybe when we gather experience, and maybe then maybe we learn that some of this is not fitted, is not suitable in my particular institution. Maybe it could be useful in your institution. If you evaluate, you could make changes as needed, and maybe you could start with this and end up with something that is the thing you actually need. Thank you for those who are listening.
Okay, actually, we thank you, Geir, for this excellent talk. And I think it was a very stimulating talk. And it's again, you did so much pioneering work on donor risks, and which helped us really to inform our donors better in a somewhat educated way. And I think this puts this whole donor information now a step further. We do have questions from the audience, actually, and I would like to encourage everyone to write your questions to the panel. Also, maybe we just start here, because I see one which kind of relates to your work that you had done so far. Should we communicate risk magnitude and explain relative versus absolute risk?
When we talk about these risks, it's when you try and explain, the ideal is always if you could explain to give to an individual the individual's future absolute risk increase in relation to a certain procedure, but I think in practice, and that is what is recommended, and that is what is the ideal. But as I just grazed upon this in my talk, and I think that that could also be viewed as kind of an illusion, because we do not know, and we will never know what lies in the future of an individual. We do not know the competing risks, and we do not know the other conditions, and we do not know diseases that may arise in the future. So, but I think we can rely on both when we try and explain things. The challenge regarding that is that if you work if you work a life within internal medicine and nephrology and transplant medicine, there is nothing actually in that experience that makes you especially good at communicating these risks. So I think you should try to rely on both types of explaining risks. And for the risk that is the future risk of end-stage renal disease in someone who is donating a kidney, then the difference between the absolute risk and the relative risk is kind of not so difficult to explain, because you could use the example of a lottery ticket and say that in itself, needing renal replacement therapy due to end-stage renal disease is a rare occurrence, like winning in the lottery. And if we say to you that donating a kidney will increase this risk by 10 times, which is the relative risk increase, that is a lot in relative risk. But since this is so rare, then it would be like buying 10 lottery tickets, and you do not actually think that you will win the national lottery with 10 lottery tickets. So with rare occurring things, then that would be a way to go. But for the other risks that are associated with kidney donation, those are not really rare occurrences, because mortality is very common because everyone will die eventually. Hypertension is very common. So for these risks, perhaps this relative risk would be sufficient, because the difference between relative risk and absolute risk is most interesting when you are with the rare occurring risks.
Okay, are you prepared for another question from the audience here? This would be, do you have any experience with the structured method of providing potential donors with information?
So this structure in this paper that we present and that we have worked out through our discussion. So I have experience with elements of that, but I have never worked in a system that has this method of doing things, and these 3 stages that are suggested. I have never worked in any system that does it like that, but so I think my straight answer would be no.
And may I follow up with a question concerning this topic? What do you think are the problems with the structured approach in a hospital in daily life or in daily practice?
Yeah, so we have this has paper has been created through, we have a lot of the co-authors here have a lot of clinical experience combined, but we have not tested this in a hospital situation. So it could be that maybe it just takes too much time, maybe it doesn't fit in a hospital situation, maybe maybe you have other things interrupting you, maybe all these criteria and checklists and structure and recommendation, maybe it doesn't fit you. So depends, maybe it depends on how chaotic your hospital setting is. If it is very structured, if you are far away from this the days in the hospital that where most of the patient work is unplanned. But if you are far away from that, if you have a structured way of doing things, then I think it could go both ways. But surely it would need some, I think you would need to be planning in advance. I think you would need to have a system around you protecting you, so that you could be able to take the time that this kind of structure approach needs.
So would Alessandra and Christophe, would you agree that we have to try until we find out to test something like that, everyone individually, but in a structured way? I think we need to test it before we can answer the question, right? So do you have any comments or questions from your side, Alessandra, Christophe, or or Geir?
Maybe just one point that to me is very important. Before, and this is something we are working on now. Before implementing this approach in our center and trying to tailoring this approach to the specific setting of the way we are dealing with living kidney donation information, there is a prerequisite which is to adjust and to adapt the materials to the specific setting of living kidney donation, and this is something that is underway, and this is something very important because so far those materials have not been explicitly adapted for kidney transplantation and for living donation. And of course, the whole concept, the three-step approach, hasn't been tested yet in the setting of living kidney donation. But before that, we need to have specific material, and we are working on that. So maybe Alessandra, you can.
Yeah, I just wanted to further build something on this issue, because basically when we started discussing about the need to test the effectiveness and the possible implementation of the model in clinical practice, the first thing that came to my mind was that we have included a number of tools that are intended to support the successful implementation of shared decision-making, but which were not validated. I mean, as Geir was saying during his presentation, they were the results of expert consensus and literature, actually, or opinions. So right now, we first of all need to make sure that those tools that we have developed are shared, and they are the result of sort of a bottom-up approach, so not something that we want to impose anyone. So I think this is the idea before we move forward with the formal pilot testing of the model. So that was just a compliment to what you were just saying.
And and maybe what is important to add here is that this has to be a co-construction, co-construction between different European transplant centers, which may have different kind of approaches in terms of the way they provide information to a living kidney candidate, but also a co-construction between other healthcare providers, integrating also previous kidney donors maybe, but also a person coming from the general population who may or may not be directly involved in kidney donation, but we want to embark that kind of people as well, because they can provide very interesting input, because we don't want to deal with only specialists. We need to have input coming from the general population, coming from the patient, also coming from patient association, because we know that this thing of shared decision making is really matters for the patient association perspective. This is something they are trying to impose to the medical community, and for the patient association, it's very important that the modern dialogue between a physician and a patient is heading to a direction where the decision is really shared, which is probably not always the case at least in my personal experience, it's not the case. And I know for sure that in France, we do believe that we are kind of naturally doing some kind of shared decision process. But when you explore more in details what this really means, you can see that you are still far from the goal that is to have really something that between the patient and the physician, the healthcare provider, something that is really discussed at the same level. And we have to fight against this natural asymmetric relationship between the physician and the patient. And this is something that is not that easy to go forward and to change.
So, Christophe, how is the situation in France or at your place? Did you connect with patient organizations already?
Yeah, I do. I'm quite involved in different patient associations, and some of them are very activist association. And I believe that actually there are at least 3 different types of actors when it comes to the decision, the medical decision. From one side, you have, of course, the physician and the medical community. From the other side, you have the patient. And I really believe that to some extent, the patient association are a different type of actor, because they are much more aware of the problem and the topic that matters in terms of decision, in terms of the natural relationship between the physician and the patient. They are much more educating in the sociological aspect of this relationship than the patient. And sometimes it's surprising to see that the real patient, if I can say, can disagree with the patient association in the way they want to provide the kind of emancipation of the patient to the medical community. And I think it's not a problem, because we have to just to admit that this is not anymore a dialogue between only the patient and the physician. And I think that in this relationship, the patient association have a word to say, and we have to be careful and to hear the voice of the patient associations. But we also have to understand that they are not systematically representative of the patient voices.
Maybe at that point, I would like to encourage all our viewers, maybe just let us know whether you connect with patient organizations, or whether you have already situations in your hospital where this is functioning, because I think we all learn from each other. But I do have a question for Alessandra. So, Alessandra, you worked with nephrologists now for 2 years, maybe. So I think you're best suited to give an outside view, and as an ethicist and healthcare insider in a way, how do we compare to other healthcare fields or other specialists? Are there anything that we can learn from them, or is there anything that you can tell us what we could do better?
I'm not sure that I can say that other healthcare fields do share the decision-making better than nephrologists actually do it. What I can say is that shared decision-making has been around in the setting of nephrology for quite a few years, especially in North America. but not as much at the European level. So just consider that one of the first articles, which was actually a clinical practice guideline addressing shared decision-making in the appropriate initiation of and withdrawal from dialysis, was published by the Renal Physicians Association and the American Society of Nephrology Working Group in 2000. So it's quite dated back in the past. But well, certainly shared decision-making and the push towards shared decision-making that Christophe was just talking about is not unique to nephrology. I mean, it has been noted as the ideal model of informed consent and decision-making in many other settings, including oncology. There's a lot of decision aids and papers pushing towards shared decision-making in oncology, but it is really largely advocated pretty much in all healthcare settings, and decision aids, believe it or not, are also being developed in settings like palliative care and end-of-life care. So it's really across pretty much all healthcare. It's really emergent.
Okay. So Geir,
so you're not so bad. This was my message. I think that there's a lot that we can do at the European level, because I think it's a cultural issue, and it's also a matter of having a different healthcare and social security systems, which maybe do not demand that push towards patient autonomy. Although our primary goal is patient autonomy, but maybe our patients are not completely prepared to be that autonomous, and our physicians are not completely prepared to give out that much autonomy to the patient. Just read me in the right way. I'm not saying that I'm against this model, because I am #1 promoter of shared decision-making. I'm just saying that maybe we're getting there more slowly because of cultural reasons.
So I think that's encouraging in a way that you tell us that we're not so bad. And
No.
at the same times, but I think we see that there is a long way to go, that we really need to do more to come to the conclusion. Probably we also should spend some more time with the patients that we sometimes seem to not provide because we're so busy. Some kind of self-criticism. So Geir, do you have any questions maybe to Alessandra or?
Well, I would just when I made the presentation, I would thinking just this usefulness of this model. I was thinking about if does the model fit. Could we give it out to everyone, and to what extent, or how often would adaptations be needed? And is it perhaps also so that some centers actually just could use some of this learning material and maybe the model doesn't fit at all? I don't know if you could elaborate some more on that.
Well, actually, the model has the potential to be fit for all, but clearly it leaves room for adaptations and further tailoring. So, for example, regarding the tools that we proposed for use within the model, the checklist simply aims to provide transplant professionals with a list of important actions to be performed during the process of informed consent. For the successful implementation of shared decision-making. But for those who are willing to adopt this model, the checklist may of course, be further adapted depending on the policies and practices in place at individual transplant centers. And as for the prompt question sheet and the questionnaire to assess a living donor's understanding prior to living donor surgery, changes may also be implemented to meet needs that may be variable, for example, depending, as I was just saying a minute ago, on healthcare, social security systems, and other features that vary across individual countries. So there's, of course, room for adaptation and improvement. I mean, that's, as you were saying before, this is a start of a journey together.
So this is a nice start. We started with a nice idea that was already published by the DESCarTES group, and Christophe, you are the chief of the DESCarTES group at the moment. What are your plans? And at that point, I would also tell the audience that it's a very active and nice group, and we encourage everyone to take part in it and to bring new prospects to the field of transplantation within the ERA, within the DESCarTES, just become members. But Christophe, what are your plans for getting further on this issue?
Well, so I think the first thing to achieve, and what we are actually working on, is to create and to build some materials that are specifically designed for the field of living kidney donation, which is obviously a very specific field. So for that, we are working and we are embarking the DESCarTES working group, but like I said, also patients, also individuals from the general population, donors, advocates, and we will probably also have some colleagues from the EQUITA working group from the ESOT. Well, we want to provide the community with a set of materials, and so that each center can pick up the material, the tools that is the most appropriate for his clinical practice. But this being said, we have to keep in mind that the ultimate goal is to go towards some kind of homogenization and some kind of standardization. So maybe that, meaning that we will have certainly to think about some kind of recommendation regarding the lowest common denominator that we want and we want to agree upon, that should be respected by each transplant center across Europe when it comes to provide information to living kidney donation and to develop this shared decision making. Just to the attention of the audience, you have here the email of the DESCarTES if you want to collaborate with us in shaping the material, the questionnaire, etc. And you have also this QR code that will directly conduct you to the material, so that you can see the material, read the material, and also have the opportunity to propose some modifications, some adjustment. So we are really looking forward to a general participation.
So thank you, Christophe. I was just looking at the watch, time is really flying. It's 6 p.m. Our time is over. So I would just like to conclude that we hope as a group, and DESCarTES also together with us, we hope that we provided some food for thought for everyone who is listening, and that we could improve our approach to the donors in the future. I would like to thank you very much, Geir, for an excellent talk. Thank you, Alessandra and Christophe, for this great discussion. I hope everybody can take some key messages back home. And at that point, I would like to conclude this session, and I wish you a nice evening. Relax and think of what our ideas are, and maybe we can improve the field further. Thank you very much, and we hope to see you again soon at DESCarTES on the one end and at other ERI seminars at the other end. Thank you and bye-bye.